Welcome to this peer voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/rkz. This activity is supported by an educational grant from Recordati Rare Diseases.
Hi, I'm Pierluigi Denzani from University of Bologna in Bologna, Italy. Welcome to this educational program on idiopathic multicentric customer disease. This four-part case-based episodes follow the idiopathic multicentric customer disease patient journey from presentation to treatment, highlighting key clinical features for this rare condition and modeling best practice management. In this first episode, we will focus on recognizing and referring patients with idiopathic multicentric customer disease. The pivotal potential pathogenesis related to the interleukin-6 and other cytokines. There are different hypotheses. The first one could be systemic inflammatory disease, the second a paraneoplastic syndrome, and also a potential virally driven hypothesis. And this is the continuous spectrum of disease presentation and the clinical severity, starting with the unicentric customer disease, moving to the oligo customer disease, and then the idiopathic multicentric customer disease NOS. And finally, the two more aggressive presentations represented by idiopathic multicentric customer disease, idiopathic plasmatic lymphadenopathy, and the last one is the CHAFRO. It is the more severe, the more risk of death for the patients. Key presentation, 42 years old male with fatigue, low-grade fevers and lumps in the neck and armpits persisting for 4 months. In terms of history, the patient reported slow onset of flu-like syndrome and an unintentional 5 kilogram weight loss. And he did need severe shortness of breath of significant swelling in his legs. In terms of physical examination, bilateral cervical and axillary lymphadenopathy, but no significant liver enlargement or peripheral edema. In terms of lab workup, we did the inflammatory markers with elevation of CRP and SR, and a very high level of ferritin. At the same time, the hemoglobin level was 10.8 with a mild thrombocytosis, and of course with a polyclonal hypergammaglobulinemia represented by high IgG levels and hypoalbuminemia. Normal liver function test and also normal renal function. At the same time, the IgV was negative, and also the hepatitis test was negative. We did also the imaging evaluation with CT scan. I think it's important to remember the concept of differential diagnosis when you talk about idiopathic multicentric customer disease among different several autoimmune disease, other neoplasias such as Hodgkin lymphoma, but also different kind of aggressive or indolent non-Hodgkin lymphoma, and at the same time some differential diagnosis with infection, in particular acute EBV, acute HIV, and also the very famous HHV-8. In terms of pathway for the idiopathic multicentric customer disease diagnosis, the first step, of course, is the excisional lymph node biopsy to test, in terms of histopathology evaluation, the potential diagnosis of customer disease. After this step, the further step is the staging, represented by CT scan and also the total body PET. And you can certify at this point unicentric versus multicentric. And I think it's fundamental in terms of multicentric idiopathic customer disease to evaluate another exclusion criteria to avoid the risk of diagnosis of infection-related disease, autoimmune disease, and also other neoplasias such as lymphoma. At the end of the day, you can have the confirmation of idiopathic multicentric customer disease on the basis of a consensus of the different criteria, major and minor. Thank you for watching. Please join us for the next episode on diagnosis of idiopathic multicentric customer disease. Hi, I'm Pierluigi Zinzani from the University of Bologna in Bologna, Italy. In this episode, we will discuss how to confirm a case of idiopathic multicenter cancer disease. First of all, the histology. There are two different situations, the hyaline vascular variant and also the plasma cell variant. I think this is the most important step to put the histological diagnosis of cancer disease and is fundamental to have a very good multidisciplinary group, and in particular, in this case, the immunopathologist. The second step is diagnostic criteria. There are inclusion criteria, exclusion criteria, but I think it's very important. The inclusion criteria, there are two different steps. The major criteria need both of them. The first one is the pathological lymph node, and the second one is an enlarged lymph node with a diameters of 2 centimeter or more to 6 centimeter, and in particular, at least 2 or more than 2 lymph nodes station. There are several minor criteria, and we need at least 2 or more than 2 of 11 with at least 1 or more than 1 from the lab criteria. And this is the list of the lab criteria and the list of the clinical criteria. In terms of exclusion criteria, of course, the malignant disease such as lymphoma, autoimmune disease, and infection-related disorder. Another important point is a differential diagnosis in terms of lymphadenopathy with the rheumatic disease, such as the systemic lupus erythematosus, the rheumatoid arthritis, and the Sjogren's syndrome. We can have a different situation according to the histology, according to the different presentation in the different side of the lymph nodes. And there is a direct correlation with disease activity on the different disease when you compare with idiopathic multicenter cancer disease. And another important point is the subtypes based on the presentation. As I said at the beginning, the unicentric, the idiopathic multicenter cancer disease NOS, the idiopathic multicenter TAFO, the poem-associated multicentric, and the HHAV8 multicenter cancer disease with different symptoms, systemic symptoms, also the differentiation according to the lymphadenopathy, and the organomegaly, that you can have a differentiation according to the idiopathic versus unicentric, and also between the idiopathic versus TAFO or POEMS or HHV8. Another important point is the abdominal inflammatory markers, the hematological evaluation in terms of anemia, thrombocytopenia, and another important point, of course, there are some difference in terms of presence or absence or different level of hypergamma globulinemia. Again, we continue with this kind of presentation, the renal dysfunction, and also the autoimmune phenomena that are different according to the 5 different situations in terms of disease, and also the pathological features that is a very important support from our hemolymphopathologists. In terms of therapies, there are really different treatments. We can start with only the local surgery for the multicenter cancer disease, moving to the systemic treatment with interleukin-6 target treatment, and for the idiopathic multicenter cancer disease, and also the same treatment for the TAFO, but with a reinforcement high dose of steroids, and there are some differentiation for the PONS and the HHV8 according to the pathogenesis. The case presentation, histopathology, was an incision biopsy of an axillary lymph node. There was an interfollicular plasma cell and hyperplastic follicles. The diagnosis was idiopathic multicenter cancer disease. The case was classified as a non-severe because the patient maintained stable organ function and did not meet the criteria for the more aggressive TAFO syndrome. Thank you for watching. Please join us for the next episode on treatment selection. Hi, I'm Pierluigi Zinzani from the University of Bologna in Bologna, Italy. In this episode, we will discuss the first-line treatment for non-severe idiopathic multicenter custom disease. I think it's very important the severity scoring for the idiopathic multicenter custom disease, represented by the ECOG performance status, and the fluid overload, hemoglobin level, the pulmonary involvement, and the estimated glomerular filtration rate. And there are 3 different levels for each of these factors: mild, intermediate, and severe. And severe idiopathic multicentric disease require having 2 of these 5 severe criteria. And the mild idiopathic multicentric custom disease require having all 5 of the mild criteria, and the intermediate case do not meet the criteria for mild or severe. Mild and intermediate case are considered to be non-severe for treatment algorithm purpose. So at the end of the day, you can consider severe idiopathic multicentric custom disease, patient with ACOG 2 or more than 2, stage 4 renal dysfunction, anasarca endoascitis and or prior pericardial effusion, hemoglobin level less than 8.0 gram per deciliter, and the pulmonary involvement / interstitial pneumonitis with dyspnea. And we are in this step of the continuous spectrum of disease presentation, the idiopathic multicentric custom disease NOS with a multicentric lymph node sites. Usually the histology is vascular or to mixed, inflammatory markers in terms of lab, and in terms of clinical symptoms, moderate and occasionally inflammatory symptoms. And this is very important table according to the treatment approach for multicenter custom disease according to the different subtypes. And you can see here in the setting of idiopathic multicenter custom disease, no severe situation, the frontline treatment is represented by siltuximab with or without steroids in front line. The potential second line could be tocilizumab with without steroids, and for the patient in third line rituximab, and also in this case with the potential combination with steroids. Could be important to remember if during the treatment in front line we can obtain at least a partial response, we have to continue the treatment until the progression, of course, in frontline, continue to use siltuximab without steroids. At the same time, for patient with an inadequate response, it means stable disease or progression, we can move to rituximab with steroids, without some immunotherapy agent, and we have different situations in terms of conventional or potential exploratory new agents. For the non-severe, for severe, but is another option that we can discuss further. We come back to the key presentation of our patient. The treatment started with siltuximab at a dose of 11 milligram per kilogram every 3 weeks. We started in October 2022. Symptoms regressed within a couple of months. Lab progressively normalized. Lymph node regressed after 3 months with a confirmation on the CT scan, and completely resolved within 6 months since the treatment start. Now still on active treatment after 3 years since the beginning of siltuximab without any kind of adverse event. Given persistent asymptomatic status with no lab alteration, he asked for treatment discontinuation. Advised not to step treatment, but a rescheduling every 6 weeks instead of 3 was considered acceptable. Next administration, therefore, due in March 2026. Thank you for watching. Please join us for the next episode on managing severe idiopathic multicenter custom disease. I am Pierluigi Zinzani from University of Bologna in Bologna, Italy. In this last episode, we discuss treatment approach for severe idiopathic multicenter customer disease. Our patients, the presentation 47 years old male, fatigue and performance status decay, fever, and some lymph nodes. With a physical examination, the lymph nodes had a size between 2 to 4, with the some ascites and bilateral pleural effusion. In terms of lab recap, we presented inflammatory markers, dermatological evaluation with severe anemia and also thrombocytopenia, polyclonal hypergamma globulinemia, and also hypercreatinemia. And in terms of tests for HIV and hepatitis were absolutely negative. The histopathology with the biopsy, we had the diagnosis from our pathology of plasmacytic features, and at the end of the day, it was a confirmation of customer disease morphology. The bone marrow biopsy was absolutely negative. And also we did the renal biopsy with the membrane polyarterial glomerulonephritis that is very important to remember during the presentation of our patient. At the end of the day, of course, idiopathic multicenter customer disease, and the case was classified as Tafel syndrome with severe presentation. You remember the severe idiopathic multicenter customer disease scoring that I discussed before. And this is the definition of Tafel with thrombocytopenia, anasarca ascites, fever, reticular fibrosis, and organomegaly. You can see here in this curve the difference in terms of overall survival when you compare patients with a classic NOS, idiopathic multicenter the customer disease, and the Tafel customer disease with a real different curves. And again, you can see according to the spectrum, the presentation of the idiopathic multicenter customer disease Tafel in terms of lymphadenopathy, histopathology, lab, clinical symptoms, and inflammatory syndrome. And in terms of treatment, again, for this severe condition, siltuximab plus high-dose steroids is the best and the mandatory frontline treatment. Potentially in second line, we can use tocilizumab plus high-dose steroids, and could be very important when you obtain at least a partial response to continue the treatment with siltuximab plus steroids until the progression. In terms of treatment for our patients, we started with steroids along with weekly siltuximab as a regular dose and schedule for the first month, June, July 2025. The steroids were tempered until discontinuation, and siltuximab shifted to once every 3 weeks administration. Rapid resolution of cytopenia, including both thrombocytopenia and anemia, and negativization of hyperinflammation markers. Symptoms improved greatly, with no more fever, enhanced performance status, and resolution of ascites and pleural effusion. Cervical lymph nodes still palpable, is on active treatment with siltuximab, 14 administration at the beginning of February 2026, and with plus 7 months science treatment onset. When there are no response or inadequate response to siltuximab, it could be very important to try to use conventional chemotherapy such as CHOP or CBP, and why not also tocilizumab or rituximab, and in particular situation to explore new agent inside clinical trial. Take-home message: customer disease is an uncommon clinical heterogeneous, mildly symptomatic most of the times, but patient may be also severely or critically ill. I think very important to remember the differential diagnosis with other disease, and siltuximab plus steroids, depending on disease severity, is the recognized frontline treatment, both in treatment naive and also in pretreated patients. Current guidelines support treatments with siltuximab, science frontline, and as soon as diagnosis is established, regardless of the burden of the disease in the clinical picture. And finally, long-term administration of siltuximab is safe and effective without any kind of cumulative toxicity. Symptomatic and lab responses occur rapidly, also lymph node involution could be much slower. Thank you for watching.
This has been an activity published by Peer Voice.